Next speaker is Roberto Novizio from San Raffaele Hospital in Milan, and he will talk about the use of thermal treatments in thyroid cancer. Please, Roberto.
Good morning, everyone. First of all, thanks for the kind introduction, and thanks to my mentor, Dr. Valcavi. And as said, my name is Roberto Novizio, and today I'm honored to speak about a really interesting topic, that is the use of laser for the treatment of micropapillary tumors. More in general, ultrasound-guided thermal ablation is a non-surgical technique that has been primarily used for the treatment for the reduction of benign thyroid nodules, but it has also been proposed for the treatment of well-differentiated thyroid cancer. Thyroid cancer is the most common endocrine malignancy, and the incidence of thyroid cancer has been relatively stable until the early 90s, after which it substantially increased. So the incidence raised from about 5 to about 15 cases per 100,000 individuals between 1975 and 2009. And as we can see in this graph, all the increased diagnosis is virtually attributable to an increase of papillary thyroid cancer, and 49% of the increase is due to papillary thyroid microcarcinoma. However, the thyroid cancer mortality has remained stable over the 25-year period, as we can see in this graph. So it does not seem to be an epidemic of the disease, but an epidemic of the diagnosis that can generate an overtreatment in people who will never develop any symptom. So let's start from the beginning. As according to 2015 American Thyroid Guidelines, the definition of papillary thyroid microcarcinoma is a carcinoma measuring less than 10 millimeters in the greatest diameter. And the vast majority of PTMC are defined as a low-risk PTMC, lacking of aggressive features such as nodal or distant metastasis, signs or symptoms of a recurrent laryngeal nerve, tracheal invasion, high-grade malignancy on cytology, and progression sign during follow-up. So according to ATA, surgery is the recommended choice treatment for high-risk PTMC, while for low-risk PTMC, alternative option can be considered. In the past, after diagnosing a nodule as a low-risk PTMC, two management options were presented rather equally to the patient, so immediate surgery or active surveillance. Patients used to choose which option they wish to pursue, so it was suspected that active surveillance would be better than surgery. However, evidence is about what were lacking. But today, according to 2015 ATA guidelines, active surveillance can be proposed as a first-line treatment for papillary thyroid cancer, for microcarcinoma lacking of aggressive feature. Although this disease progression of papillary thyroid microcarcinoma is infrequent, in a 10-year active surveillance follow-up of 1,235 patients made by ITO, about 3.8% of patients developed the nodal metastasis, and about 8% showed tumor enlargement. And moreover, most patients are understandably concerned about their cancer, and thus for repeat and a regular follow-up if the cancer is left untreated. So since 2011, some scientists started focusing on thermal ablative therapies for the treatment of low-risk PTMC. During this presentation, I'm going to talk about laser ablation, but there are other ablative therapies that can be used. And high-quality evidences about safety and efficacy of those treatments are still lacking, so it is not surprising that in ATA guidelines, those are not even mentioned, but according to many studies about that, they seem to be really promising methods. So really briefly, we can see that laser technology has a broad clinical application in many diseases, such as a hepatocellular carcinoma, or thyroid nodules, or unresectable breast cancer, or renal tumors. Different results have been obtained during last year by laser, based on the type, the size, the localization of tumor, but also the patient performance status, and last but not least, the expertise of the operator. So even though surgical excision remains the first therapeutic option in patients with thyroid cancer, in recent years, laser ablation has been applied to treat patients unsuitable for surgery with promising results. So in 2011, the first laser ablation trial in one PTMC patient was performed by Dr. Papini. In 2013, Dr. Valcavi demonstrated for the first time the complete histological destruction of PTMC after laser ablation. And a few years later, first retrospective studies with a larger series of patients start to be published. And at last, 3 months ago, the first comparative studies between laser ablation and surgery came out from Weizhou. So again, let's start from the beginning. And in 2011, there was the first ultrasound-guided percutaneous laser ablation for local treatment of PTMC in an otherwise inoperable patient. The patient was at high surgical risk, so she was an 81-year-old woman with decompensated liver cirrhosis and renal failure, and she had a breast cancer recently treated by surgery, followed by external beam radiation therapy. And she was found to have a 7x7 per 8 millimeters nodule in the right lobe at the ultrasound examination, diagnosed as a PTC by cytology. No cervical or lung metastasis revealed by ultrasound or a CT scan, and normal thyroid functioning test. So the first treatment of a PTMC was well tolerated. Renal and liver function were not affected by treatment, and ultrasound-guided final needle aspiration biopsies and core needle biopsy performed at 1 and 12 months showed no viable neoplastic cells. And another fine needle aspiration biopsy performed at 24 months confirmed the absence of malignant cell, showing just necrotic material, charred debris, and fibrosis. At last, there was no evidence of disease recurrence after 2 years of follow-up. So now we are in 2013, and for the first time, there was the demonstration that laser ablation is technically feasible for the complete histological destruction of PTMC. To do that, 3 patients underwent percutaneous laser ablation in operating room under general anesthesia. And after the minimally invasive procedure, the surgeon directly started the total surgical thyroidectomy. So cutoff enrollment for patient was fine needle aspiration biopsy positive for PTMC, ultrasound evidence that only one nodule measuring less than 10 millimeter in the greatest diameter, no other evidence of tumor in the thyroid gland or neck, and normal thyroid functioning test. Subsequent to surgery, thyroid glands were submitted of histological evaluation, and a tumor and surrounding parenchyma vitality were evaluated by immunohistochemistry using both TTF1 or thyroid transcription factor 1 and anti-human mitochondrial antibody. The histological features were comparable in all 3 cases. So the microscopic examination shows, as we can see in the image A, shows a well-defined brownish area 5 millimeter across. And the microscopic examination shows, as we can see in the image C, showed just carbonized tissue. And in the whole patient, in the whole ablated area, and in the rim of the normal tissue surrounding the tumor, as we can see in the asterisk of image D, there was a complete loss of TTF1 and anti-mitochondrial antibodies, but as we can see in the insert, in the right insert of image D, in the non-ablated tissue, the immunoreactivity was easily detectable. So this demonstrates that the treated tissue, the ablated tissues, was irreversibly damaged. And at last, BRAF mutation was found in cases 1 and 2, but no correlation with the histological features was noted. So that seems to be okay, but in cases 2 and 3, incidental papillary microfoci were found far from the ablated zone. And in case 2, a micrometastasis was observed in one perithyroidal lymph node. So conclusion of this study are that percutaneous laser ablation is technically feasible for complete PTMC destruction, but the limitation of laser approach is that the US examination does not allow to detect tumor foci within thyroid or in a locoregional lymph node. So laser ablation may become a primary choice treatment for PTMC if future new knowledge will permit preoperative detection of multifocality and lymph node metastasis. So now we are in 2018, and the first retrospective study on 64 patients were published. Actually, preliminary results of this study came out in 2016, And the aim of the study was to evaluate the efficacy and safety of percutaneous laser ablation of a unifocal papillary thyroid microcarcinoma. To do that, following these inclusion or exclusion criteria, such as cytological diagnosis of PTC or US ultrasound showing just a single lesion measuring less than 10 millimeters, or no course classification, and so on, 64 patients were evaluated and studied. So patients have been followed by conventional ultrasound, contrast-enhanced ultrasound, fine needle aspiration biopsy of the ablated zone, thyroid functioning test, and chest X-ray and CT scan. The results of this study were that the laser ablation treatment was well tolerated in all patients, so no major drawbacks were observed. Just two patients, in just two patients, incomplete ablation were detected by contrast-enhanced ultrasound, so a complementary ablation was performed. At final conventional ultrasound follow-up, 79.7% of the ablated zone completely disappeared, but while in 20.3% of patients there was a scar-like lesion, as we can see in the image, so this little white spot. And US-guided fine needle aspiration biopsies performed at 1, 6, and 12 months showed no viable neoplastic cell, and at last there was no regrowth detected in all patients. So again, that seems to be okay, but in one patient, one metastatic lymph node was detected 30 months after laser ablation. So patient underwent thyroidectomy and central lateral cervical lymph node dissection, and no adhesion or inflammatory change in the tissue were noted during surgery. So conclusion of this study by Liu Zhang are that laser ablation is effective and safe to treat solitary low-risk PTMC. Contrast-enhanced ultrasound performed immediately after ablation is useful to detect incomplete ablation. But again, the limitation of laser approach is that US examination does not allow to detect more tumor foci, and so laser ablation may become a primary choice of treatment for PTMC if new knowledge will permit preoperative recognition of multifocality. The study has three main limitations that are the short follow-up period, so long-term outcomes are not certain, and that is really important. Small sample size, and post-treatment fine needle aspiration biopsy that could produce false negative results. So the last study that I would like to analyze with you has been published just a few months ago by Liu Zhang, and it is the first comparative study with laser ablation and surgery. It's a retrospective study, which aims is to compare the clinical outcomes of US-guided laser ablation and surgery for treatment of solitary PTMC. So to do that, 81 patients were included in this study, following these inclusion-exclusion criteria that are quite similar to the previous study. So cytological diagnosis showing PTC, single lesion measuring less than 10 millimeters, so we're talking about a low-risk PTMC, no cause calcification, and it has to be a lesion that is not difficult to treat by interventional therapy. And among those 81 patients, 36 patients underwent ultrasound-guided laser ablation, while 45 patients were treated by surgery, specifically hemithyroidectomy with the ipsilateral central compartment dissection. So after that, patients have been followed up by conventional ultrasound, fine needle aspiration biopsy, just for patients who underwent laser ablation, obviously, and a thyroid functioning test. So this slide shows the results of the study. So about the 36 patients who underwent laser ablation, just one patient developed transient hypothyroidism at 1 month after laser ablation with spontaneous recovery after 2 months. So treatment was not needed for this patient. No regrowth of treated tumors was noted in all patients, and fine needle aspiration biopsies performed at the ablated zone showed no viable neoplastic cells. And recurrence occurred in 2 patients. So one patient had a metastatic lymph node diagnosed for 30 months after laser ablation, and one patient had 2 PTMC foci in contralateral lobe diagnosed 32 months after laser ablation. About the 45 patient who underwent surgery, one patient developed transient hypocalcemia. Hosteness was observed in just 2 patients with spontaneous recovery after 3 and 6 months, respectively. And the recurrence occurred in 3 patients. So 1 patient had a recurrence in the contralateral lobe, while 2 patients had metastatic lymph node. Some data are briefly summarized in this table, where we can see that there were no statistically significant differences between surgery and laser ablation about complications rate, regrowth, recurrence rate, and recurrence time lag. So the study concludes that compared with surgery, laser ablation seems to be also a safe therapy for treating solitary PTMC with good therapeutic effect. And laser ablation might be an alternative treatment to surgery for patients with solitary PTMC ineligible or refusal to undergo surgery. But this study has the same limitation of the previous one. So again, short follow-up period, small sample size, and post-treatment fine needle aspiration biopsy that could produce false negative results. So again, this slide that helps us to summarize our travel through the use of laser to treat PTMC during last decade, but the real question is what next? So in order to better understand the real strength and above all, the real indication for laser use in thyroid papillary microcarcinoma, we still need bigger sample size studies. We need long-term follow-up studies to better evaluate recurrence and metastasis after laser ablation treatment. And we need comparative studies of surgical, non-surgical, and active surveillance approaches. So those are some take-home messages from this presentation. Percutaneous laser ablation is technically feasible for the complete PMC destruction, and laser ablation may be useful in selected patients with PTMC, for example, low-risk PTMC or high surgical risk patients or surgical treatment refusal. And compared with surgery, laser ablation is also a safe therapy for treating solitary PTMC with a good therapeutic effect. And laser ablation may become a primary choice treatment for PTMC if future new knowledge will permit preoperative detection of multifocality and lymph node metastasis. And before saying you goodbye, I would like to share with you this quote from Khalil Gibran about progress. So progress lies not in enhancing what it is, but in advancing toward what will be. Thank you very much for your attention.
Thank you, Roberto. Please, any question from the audience?
Thank you, Roberto, for your presentation. I had the laser at that time. I believe that we may obtain the same results with other thermal techniques. My question is, Professor Mercante, who's there in the audience, published in 2009, is it right? A series on thyroid or head and neck, I don't remember. A series of 445 patients who had been operated on for thyroid micropapillary carcinoma and had as 40% metastatic disease in the central compartment. They had all of them had central neck dissection, and 40% of them had metastatic disease. So I'm surprised, I'm a little bit surprised by the fact that we don't find in these studies you've shown any or a small amount of metastatic disease in the central compartment, or what happens with multifocal disease, which it was observed in my first study in 2013.
Thank you for your question. And first of all, yeah, I think that studying papillary thyroid cancer after surgery may show that about 20 to 40% of patients had metastatic lymph node. But we just saw here that just, for example, one patient out of 64 or one patient out of 36 treated in the second study that showed for the comparison between laser ablation and surgery had a metastatic lymph node. I think that the answer is that this study has a short-term follow-up, so maybe it's possible that if we wait another 10 years or more, the percentage of people who showed metastatic lymph node may increase, and maybe I also think that not all metastatic lymph node is a real danger. Maybe there are some metastatic lymph nodes that are not going to grow so fast, or they are growing, but they are growing really slow. So maybe patient is going to cure other disease than papillary thyroid cancer, and that's why if we choose active surveillance and not immediate surgery, it's probably that some patient then will have to go to surgeon, but it's also more probably that patient will not, because those metastatic lymph nodes are not real dangerous metastatic lymph nodes. But to say that we still need more studies, long-term studies, and I think that one interesting point, as Stephen Odak just said, is that we need a comparative study. We need to know if we treat a patient with PTMC, the probability that this patient will have a metastatic lymph node is higher, is the same, or is lower than if we do not do anything. So maybe, I don't know if I answered your question.
So Roberto, you think that the aggressiveness of the cancer is the key point? I mean, as Stephen Odak said before, if we know better the biological aggressiveness of the cancer, we can better decide if the patient is candidate to surgery or to thermal treatment. This is the point, you mean?
Sure, and I was going to say that the conclusion of the 2013 study are still good for today, but I had to stop because I heard Stephen Odak's speech, and I think that is the really important part for the future treatment of patients. So if we know that the genetic of tumor is not so aggressive, we can treat it by minimal invasive surgery. We can do a good risk stratification of patients, and that's what we cannot do now because we do not have enough data to know who is the perfect patient, the ideal patient to go to thermal ablative therapies or active surveillance or immediate surgery. We are still in the middle, and I think that to go forward, we need a genetic study and something like this.
Very good. Thank you, Roberto.